Assalamu alaikum wa rahmatullah. The article of this week is published in a new journal called Sapiens that started 2025 and driven by Dr. Riccuci and Dr. Sekera, published every 6 months, and they publish scientific articles, reviews, case reports, all in the endodontics field. And the best thing about it is that all the articles are free of charge. So the article is titled Biological and Procedural Factors Affecting the Outcome of Apical Microsurgery, a case report done by Dr. Riccuci in 2025. So this article reports a clinical case of post-surgical apical periodontitis associated with a tooth exhibiting a failing root and filling with a bioceramic material. A persistent bacterial infection somewhat favored by technical issues was the most likely cause of the post-surgical disease. A 61-year-old male who's hypertensive, poorly controlled diabetic, and he has end-stage renal disease. He came complaining of tooth number 30. The tooth was slightly tender to vertical percussion, and the probing depth were within normal limit. The periapical radiographs showed that the short root canal filling and periapical radiolucencies were present at the mesial and distal roots of tooth number 30. So a non-surgical root canal retreatment was done for the patient. After 6 months, the patient returned for follow-up examination. The tooth had been asymptomatic, but a PA showed that the mesial and distal radiolucencies had slightly decreased in size. And after 12 months of follow-up, a periapical radiograph revealed that the radiolucencies had remained the same size. So a CBCT scan was taken at this follow-up, and it revealed that the presence of a masked buccal canal in the distal root. So apical microsurgery was planned, and in the surgery no fracture line was noted. A follow-up radiograph after 8 months, it showed complete bone healing. Then after 46 months after the surgery, the patient was referred back to the clinic because of a sinus tract and a deep pocket which is 10 millimeters in the mesobuccal area. The PA and CBCT both revealed periapical radiolucencies on both roots and an osteolytic lesion interradicularly. And in the axial scan, it revealed a V-shaped bone dehiscence buccally along the whole mesial root, suggestive of vertical root fracture, so a resurgery was proposed. In the second surgery, a fracture line was present, so the soft tissue lesion and the cortical bone fragment and the resected apex of the distal root was done and sent to the histological processing. After that, the tooth was extracted. For the histopathologic and histobacteriologic observations, sections of the periapical soft pathologic tissue revealed that the lesion was a non-epithelialized granuloma. For the distal root apex specimen, serial sectioning was done, and it showed that the dentin on the resected apical surface was covered with a layer of newly formed stratified cellular cementum, and there was unprepared canal space coronal to the retrofilling, and it was densely packed with necrotic debris and bacterial biofilms. The mass of bioceramic material filling the root and cavity appeared to be heavily infected. Bacterial aggregations were observed, colonizing voids and fissures throughout the entire extent of the root and filling. Also, sections through the isthmus revealed that the root and cavity was poorly extended in a coronal direction. The overlying isthmus was clogged with necrotic debris and biofilms. So a residual bacterial infection, favored by substandard technical surgical issues, was the most likely cause of the periapical inflammation. It was also apparent that the root and filling was not placed along the long axis of the canal to the depth of at least 3 millimeters, and also it was quite apparent that the bioceramic material used as root and filling may have lost its antimicrobial effects and sealing ability with time, allowing bacteria to leak across and grow on it.